objective today, we're going to review and evaluate common hip conditions in the growing patient. We're going to assess treatment of common conditions in the pediatric hip, including slip capitofemoral epiphysis. We usually call this SCFE for short. If you're in Australia, they call it a SUFE. A lot of different names for it, but oftentimes you hear me say SCFE. You can see it right there, big letters. Pelvic avulsion fractures, developmental dysplasia of the hip. We also call that DDH. And Legg-Calve-Perthes disease. Sometimes we just say Perthes disease for short. We're going to introduce common diagnostic and current evidence-based treatment, and maybe just have some good discussion and dialogue about how I like to do things, what the literature shows, and perhaps Skip and Matt will tell us a little bit about their viewpoints as well. These are some excellent resources for you guys. These are really common conditions for a budding orthopedic surgeon. You really should get to know the basics if you ever have an opportunity. These are great resources for you, both from JBJS as well as what we call the Yellow Journal, or the Journal of the American Academy of Orthopedic Surgeons. You know, the growing hip, the reason why it's important is because it has certain characteristics to it that are different from adults. You'll see that it's a bit of a theme in pediatric pathology, is because things are still growing. I'm sure you guys know this already, but the physis is really the growth plate. And the physis around the hip joint, you really have several, but we're going to really focus on three of them. You have the acetabular physis, which is the triradiate cartilage, which is where the three bones around the pelvis come together, and we call it the acetabular physis. It usually starts to close around 12 if you're a female, 14 if you're a male. The proximal femoral physis, okay, that's outlined there in red. It's another growth plate. It usually appears on x-ray at a very young age, usually when you're about a half a year old, and then it can close in late adolescence as well. And then you have your greater trochanter apophysis. Now, an apophysis is something a little bit different. An apophysis is where a tendon attaches to a bone that is really a secondary growth plate. So it doesn't always contribute to longitudinal growth, but it does contribute to growth. The most common one is where your patellar tendon attaches. We call it the tibial tubercle, and that's an apophysis. In the pelvis, you'll see that there's a lot of apophysis around there. Now, again, these are areas of cartilage that are really secondary growth plates where you have major muscle groups attached to. It's kind of important because it really helps you with your diagnostic exam and some injuries as well. So I've outlined here in yellow some of the apophysis around the pelvis. You can see your ischial apophysis is where your hamstrings originate from. You've got your hip flexors, you got your sartorius and your rectus femoris. Those are those little comma-shaped things on the pelvis as well. You've got your hip abductors from your iliac crest. You can feel those on any of our hips. Then you got your abdominal muscles that really attach into your pubis as well. So this term apophysis is something that's not always very common to a lot of people when they start learning orthopedics. So it's good to have a good basic knowledge of them. Hip conditions in the patient. Many of you guys know we think a lot about differential diagnosis. You have someone come in that has hip pain or a hip problem. Well, in kids, it's a little bit different. Over on the left is a column of perhaps some common adult problems with the hip. Well, when you put the word young into it, you almost double your differential diagnosis. Conditions that do not always happen in adults. So things like Perthes disease or osteonecrosis, hip dysplasia. Infections are much more highly prevalent in the pediatric population than it is in adults. So we're going to transition now to the slip capitofemoral epiphysis, or SCFE for short. And it's really important that you understand the anatomy here, because you've heard me use the term physis. The epiphysis, okay, epiphysis, is really it's adjacent towards the end of the bone from the growth plate. And so as you can see there, the area in red is your growth plate, or we call it the physis. Epiphysis is the bone on top of it. So it's the ball in the ball and socket joint of a hip joint. Now, what happens when you have a SCFE, it's a little bit like a stress fracture of the growth plate, where the ball starts to fall off the growth plate. Okay, sometimes people refer to it like an ice cream cone. It's like your ice cream scoop is falling off the ice cream cone, and you can see that there. The top image starts to look a little bit normal. That bottom image, you can see how that semicircle is starting to fall off the bone. I got a lot of examples, so if you don't understand it now, you will in just a second. Most always, the epiphysis slides posteriorly or to the back. This usually happens in your adolescence during your growth spurt, okay? Usually in males, it happens when you're 13, 14. In females, when you're 11 and 12. It can happen on both sides, okay? So bilateral disease can happen sometimes about a fourth of the time. Usually we look at some radiographic markers to determine if it's going to happen bilateral. We'll talk a little bit more about that later. If it's going to happen on both sides, it usually happens pretty quick, okay? Now you can see this is not terribly common, but pediatric orthopedic surgeons do see this a lot. We commonly see this in obese patients. It's mostly males, African American, Pacific Islanders, Hispanics. If it doesn't fit that criteria or that classic patient, if you will, then we start thinking about some endocrine disorders or other reasons why you have this condition. You know, we think it's kind of an overuse condition of the growth plate. So there's got to be something else from a metabolic standpoint that's causing it. Now, like I said before, that top image really shows that it's really like a shear stress. You can see how you have, now that's an x-ray of the right hip. You've got the bone coming up and you've got that semicircle, which is the epiphysis. It looks like it's starting to fall down. You can see how if you have a really obese patient, how it produces a lot of shear stress and it just starts to come off. Things like hypothyroidism is very common. You'll see that in your test. It's a common pimping question. What endocrinopathy can cause this? Hypothyroidism. Growth hormone replacement can cause it. We see it a little bit higher prevalence in kids with Down syndrome and other metabolic disorders as well. So it's important to kind of know some of these reasons why they happen and to think about it when you see some patients. We always want it, there are different layers of the growth plate. We won't go into that today, but it's important to know that when this slip occurs, it occurs through the hypertrophic zone. It really widens, and then that's where you get weakness within the growth plate, and that's where you see that slipping effect. Again, this is a great histologic demonstration of how that ice cream scoop is falling off the cone. This is a classic physical exam finding, okay? When you flex the knee, and instead of going straight forward, it immediately externally rotates. We use that term obligate external rotation, which means I'm not externally rotating it. That patient is naturally externally rotated because the shape of the femur has changed. If you have a patient with that, they really have a SCFE until proven otherwise. You've got to get X-rays, put them onto crutches. Sometimes you can watch them walk and that foot will turn out ever so slightly. They oftentimes will say, well, I have a limp and it's not painful, or their hip hurts. You got to watch them walk. You do a hip exam. You compare side to side, make sure it's symmetric or asymmetric. And sometimes they'll have some weakness. Oftentimes when you flex the leg up, you cannot internally rotate it at all. On X-ray, so this is an AP of the pelvis. I'll tell you right now, on my left, but on the left, my left of the image, your left of the image, which is really the right hip, you can see it's a ball and socket joint. That right one looks pretty normal. On the left one, you can see the growth plate starting to widen a little bit. It's great because it's got a great side-to-side comparison. And then there's something called Klein's line. You see how when you go up the femoral neck, you almost can go straight all the way up without hitting the epiphysis. If you do that side-to-side comparison, it becomes quite obvious. And that is a positive sign for a SCFE, when sometimes you can see subtle findings on the AP. Sometimes it's not so obvious, so you got to look for these clues like Klein's line to be able to detect it. You can see in this patient right here, when you look at the frog pelvis, so when you suspect a SCFE, you want to get an AP frog pelvis, and you can see on that left hip there, it looks clearly different from the right hip, where you have gapping and that ice cream scoop is starting to fall off the cone, if you will. And there's just, I know it's always hard to look on these computers sometimes, so there's with it blown up. It is always important to get a AP of a pelvis because you get to have an opportunity to look at both sides. And sometimes you'll have a kid that comes in with right hip pain and his left hip also has the condition as well. So it's always important to get the AP pelvis as well as the frog pelvis as well as the frog pelvis, which gives you a lateral view of the hip joint. classification, it's really ranks on severity. And there's a couple ways to do this. You can look at what we call the head to shaft angle or southwest angle. That's really the top right, where you look at an angle perpendicular to the epiphysis, and based on the angle that you get, tells you the severity of it, mild, moderate, or severe. You can also look at overall neck displacement. That image on the bottom image demonstrates that quite well. You look at different percentage of how much that ice cream scoop is coming off the cone, varying from 0 to 50. If it's greater than 50, we know it's a pretty severe deformity. Although deformity is really important, probably the most important thing to an orthopedic surgeon or anyone that's taking care of this is really stability. We want to know, is it a stable SCFE or is it an unstable SCFE? Most are stable. They are able to walk. They just have some hip pain. The good news is if we treat it, the rate that they develop avascular necrosis or a long-term problem is about 0%. If it's unstable, the rate of avascular necrosis, which is where the blood supply, you lose the blood supply of the hip, is about 20 to 25%. So it's a big deal. It's a detrimental situation and condition. So an unstable slip can be really bad. We'll talk a little bit more about that later. Oftentimes, a stable SCFE walks into your clinic, has hip pain. The unstable SCFE acts like a fracture. They cannot bear weight. They're thriving in bed. It hurts. That's why I say fracture-like symptoms. And so you can see that it's unstable because that the ice cream or the epiphysis is falling off and it's actually unstable. It has a lot of mobility to it and it causes quite a bit of pain. So your initial management. Orthopedic surgeons, we don't think a lot of things are truly emergencies, but we really think this is one of our big urgencies, if you will. If you suspect this or you think you're going to have it, no more walking. They're wheelchair. Sometimes I don't even let them use crutches. I give them a wheelchair. I take them straight to the emergency room. I admit them. I do not let them put weight on it. Put them at bed rest. I do not send them home. We've got to consider looking at the other hip as well because it can happen on both sides, and we want to make sure we don't miss that. Sometimes you can have someone come in with a stable SCFE and they just step on it wrong, and next thing you know, it becomes unstable. That picture's trying to demonstrate what that might look like. The problem is once it becomes unstable, losing the blood supply and the risk that you have a bad problem with the hip long-term becomes much higher. So it's a big deal to us. So treatment options. So you have a slip and you have a SCFE, or you have a kid come in and you have a suspicion of a slip capitofemoral epiphysis. You admit them, you get them ready to go to the operating room. And I may just ask Skip, on a stable SCFE, we all have we all have different treatments. What's your treatment for, what do you do? What's your surgical plan for a stable slip?
Typically, if they're stable, I'm going to take them, urgently as is feasible, to the OR. I'm going to use a regular flat top table, not a traction setup. And I'm going to typically use one screw, either somewhere in the 6.5 to 7.3 sort of range, depending on how big the patient is and whether I feel like that screw will be of sufficient size.
Great. And Matt, when will you, if you have a kid with a SCFE that you're going to treat surgically, do you ever consider treating the other side?
Yeah, I frequently consider treating the other side. If they're a younger patient, or if they have one of those endocrine abnormalities, if their triradiate is open, that's kind of in my algorithm to go ahead and prophylactically treat the other side. One of the things that comes into play is follow-up of those patients. If you don't treat that other side, you've got to make sure that you really stress to the parents that they need to come back and see you if the child starts experiencing knee or hip pain on the other side, and not ignore that. But frequently I will pin the other side.
Yeah. So excellent points. And yeah, I think I usually would really, I want to really echo both of those. If it's a stable SCFE, sometimes we just put a single screw in it. It's pretty easy. It actually holds the epiphysis there quite well. We call that percutaneous because we don't really make a big skin incision. In situ, which means we don't move it, fixation. Okay, so that's that first bullet point, number one there. That's what it looks like. You just throw a screw in it and you leave it alone. And I'm sure there's a lot of different ways and types of screws that we can talk about at another time. I like to use fully threaded screws. You really want to get enough screws across to where you have a good fixation. The kind of the rule of thumb is you want at least 4 threads to get enough fixation. There's been some biomechanical studies that have demonstrated that. An unstable SCFE, the one that acts like a fracture, can be a little bit different. I told you we did in situ fixation earlier for stable. When it's unstable, sometimes you may want to gently manipulate it. Sometimes you do a big open procedure for it and you put 1 or 2 screws because it's unstable. It's actually mobile. And you want to do a decompressive capsule because sometimes that can put a lot of extra pressure within the joint. Now, listen, a lot of bad things can happen. We talked about osteonecrosis, where you lose blood supply of the hip. It's almost guaranteed arthritis. Chondrolysis, you lose the cartilage. You can have impingement of the hip. I'm showing you that on that image on the right. And then long-term arthritis as well can be really important. So take-home messages: an adolescent who's obese, who's limping, who has hip or knee pain, their foot turns out or they have obligate external rotation, think SCFE. Don't forget, if you have this patient and they just have knee pain, you still got to think about SCFE because referred pain is extremely common in this age group. And you need to make an assessment about stability are probably some of the most big take-home points. And also, if you're going to be involved in ordering imaging, you got to get an AP pelvis and a frog pelvis. I'm just going to briefly mention apophyseal avulsions. This is where the apophysis actually pulls off of bone. It's a pelvic fracture, right? The contraction of that tendon pulls it off. You can see that right now where that iliac crest and part of your ASIS, so a little bit of your hip flexors, pulls off the bone. Sounds bad. Sometimes a radiologist will say they have a big pelvic fracture and you start to worry about it. Here's what the MRI looks like. The reality is they typically do really well. Many times we treat these like groin strains. And if you just let the bone heal, the body will heal these quite well. We don't think there's a lot of long-term problems with them. They can happen at all areas of the pelvis, as you can see here. Most commonly, it's the AIIS, where your rectus inserts. You'll see it in like runners and sprinters and soccer players. And then obviously you can see it in those other areas too. More commonly in males than females, around 14 years old. Again, like I said before, your sprinters and your soccer players are the most common. Usually we treat this non-operatively. It almost sounds worse than it is sometimes. We want to get them moving pretty early, but you want to make sure that they don't have any pain until you start really working with their strength. I usually tell them about 12 weeks till they can get back to playing. Now, we do fix these every once in a while. Most commonly, it's the ischial tuberosity. It's the one that pulls off the bone with your hamstrings. These just don't do as well without surgery. So if they're really displaced around 1.5 or 2 centimeters, because it's really close to the sciatic nerve, they can be really painful, really weak, and we'll sometimes fix these. And these, otherwise, it's a pretty, almost a benign groin strain, in which not a lot of surgery, but an important condition for you guys to be aware of that happens.
Hip. And despite screening, so when med students, when y'all are on your rotations through newborn nursery or pediatrics, is every newborn baby gets an examination, and what we're looking for is they're looking to make sure that the hips are not dislocated. But despite this, we continue to see that it's an issue that comes up over and over again. And it's important to remember that developmental dysplasia is a spectrum of abnormalities. Not every condition is present at birth. Not all of them are detectable at birth, and there's these variations that range from the frankly dislocated hip at birth to one that's got some slight instability or some subtle dysplasia that's not recognized till later. And so for the normal development of the hip joint, like we were just looking at, is that femoral head has to be concentrically reduced within the acetabulum. There has to be good pressure on that triradiate cartilage, because both the acetabular side and the femoral head side develop reciprocally from that pressure. And you can see that in some of these slides here. So without that reciprocal formation, the acetabular side or the socket side becomes shallow or more vertical, and that dysplastic hip can be located. It can be subluxated, so one that shifts kind of in and out of the joint, or it can be dislocated. And that hip can be dislocatable, so a hip that's in at rest, but you can take out, or it can partially come out, so subluxable, or it can be relocatable or irreducible. So trying to realize that this is a whole spectrum of anatomy. Now, why does it happen is probably 1 in 1,000 are dislocated, with slightly more, 10 times that being having subluxation or dysplasia. And we do see that it's higher in certain cultures, such as the American Indians, probably because of some of cultural swaddling techniques where they're kind of pinning the hips in extension and adducted or towards midline. There are risk factors that you have to know that show up on all the tests that you're ever going to take, and some of those are female firstborn children if there's a breech position. But even depending on what type of breech, as you can see with A, B, and C here, that frank breech or C with both of the hips flexed and the knees extended has the highest incidence of dysplasia. Family history is also very important, and then other kind of packaging disorders such as lower extremity deformities or oligohydramnios. So female, firstborn, family history are some of the really important questions that you should talk to whenever you're evaluating a family or a mother and father with a concern for this in their baby. So the physical exam is really dependent on the age of the child. The easiest time it is to detect it is in that newborn period, and trying to differentiate. What we can see here is what is a Barlow hip. So this is a Barlow positive hip. So this hip is in at rest, but with adduction and posterior pressure on the hip, you can take that hip that's in socket at baseline and dislocate or subluxate it out the back. That's a Barlow positive hip. As opposed to it's not showing up here, an Orthopaedic positive hip is out at rest, and you have to actively abduct the legs to relocate that hip. And so that automatically tells the person that's caring for that hip that an Orthopaedic positive hip is already more severe on the scale, because that hip wants to be out. It wants to be dislocated at rest. As the child gets older, sometimes you can see some other signs. The Galeazzi sign is seen here, where it looks like there's a relative shortness of the femur, but in this baby's left leg, what you're actually seeing is the posterior dislocation of that hip, and so the left femur appears shorter. As the child gets older, it's hard to do things such as a Barlow maneuver or Ortolani maneuver, and frequently the consult that you'll see on an orthopedics rotation is asymmetric gluteal and thigh folds, or what looks like a relative limb inequality, because that dislocated or subluxated limb is shorter. So early in the physical exam, the key finding is a decrease in hip abduction. So even newborn children can widely abduct their hips to about 80 degrees when measuring from horizontal or from vertical. So 80 degrees towards horizontal. If you've got a child whose hip only abducts to about 60 degrees or even less than 50 degrees, you've got to be very suspicious that the reason it's not abducting is because of that hip subluxation or dislocation. As Henry talked about, frequently when we look at x-rays, we've got a good control group by looking at the other limb. And so if it's a single hip, if it's just the left hip that's out, you can compare the abduction between the left and the right. Where you can get into trouble is in a child that has both hips that are dislocated and both hips only abduct to 45 degrees or so. As that child gets older, frequently the way that they'll present is once they start walking is an appreciable limp. And so they've got, if one hip is out, they'll have a limp where it looks like there's a relative limb length inequality where that leg is shorter. If both hips are out, they can actually have hyperlordosis, meaning increased sway of their lower back as they try and compensate. And they have this kind of waddling or Trendelenburg gait. So it's really important when you're evaluating children to watch them walk up and down the halls and listen to mom and dad what their concerns are. So what do we do as far as imaging or workup for these children? Well, x-rays would be great, except that in the newborn period, a lot of the femoral head hasn't ossified, and so you can't really see where that femoral head is in relation to the acetabulum. So up to about 3, 4, sometimes even 6 months, we use ultrasound instead of radiographs. And then once they get to that 4 to 6 month time frame and you start to see that femoral head ossification, you can use plain x-rays. So this is an image that shows an ultrasound. And the way I like to teach our residents is we think of this as an AP pelvis that's been flipped on its side. And so superior is to the left on this screen, inferior is to the right. And you can see the ball here is that unossified femoral head cartilage. Your hip abductors are laying out here laterally, and the ilium is here like a straight line. And what we want to see is that if we draw a line straight down the ilium, that it bisects or at least covers up 50% of that femoral head. We also want to look at this alpha angle, which kind of tells us what the deepness is or the sharpness of that socket, to make sure that it's developing normal. So as that angle gets increased, goes above 60 degrees, that means you have, again, a more vertical socket or a shallow socket that's indicative of dysplasia. Again, once they reach the age of 6 months, you can start getting plain radiographs because we'll see the femoral head ossification center. And so looking at some just general markers, if you take a line straight through the triradiate cartilage in the horizontal, that's called Hill-Greiner's line, and then a line over the lateral aspect of the acetabulum is Perkins' line. We want to see that femoral head come in low and inside. So below Hill-Greiner's line and medial or more midline to Perkins' line. So in a normal hip like this, you can see that it's developing. You can also look at your acetabular index, which is an angular measurement to see how that acetabulum is developing. So again, a higher number is a more vertical or shallow socket. So if you have a child that has developmental dysplasia of the hip, the treatment goals should be to first get the hip in. You want to keep it in, and then you want to avoid complications. The easiest way to kind of think about this is based on age, because of course we don't want to do any harm. So in the really young patients, birth up to 6, maybe even 9 months old, we can use what's called a Pelvic harness, or a harness that is placed. And what it does is it puts the hip into that safe position of hip abduction and slight flexion, where again, an ortholani positive hip that is out wants to reduce with hip abduction. So this is a brace that the child wears full time to keep the hips abducted, so it gets that femoral head to seat in the acetabulum. We follow these children really closely. In my clinic, they come back weekly with ultrasounds at weekly visits to make sure that we're getting the hip in, because it may not go in on that first visit. It may take a week or two, but we want to make sure that we're getting the hip in and that we're starting to see some of those ultrasound measurements of the alpha angle begin to normalize as the socket deepens. And then once that hip is stable, typically the child wears this full time for about 3 months and then decreases to nights and naps. There are complications with anything, potential complications with anything that we do. You can get avascular necrosis, which again is that compromise to the blood flow to the proximal femur if you force the hip in too much abduction or force it in too much flexion. You can also get a femoral nerve palsy if you really flex the hips. And so the easiest way to check that is just ask the parents if the child is kicking his or her legs inside their harness, because if you've flexed them up too much and they get a femoral nerve palsy, that will get better if you decrease the flexion in the harness. The downside is that's proving to be a very difficult hip to gain a reduction in with a harness. So what if our harness is unsuccessful, or maybe the child doesn't show up till a little bit later in life? You can do a closed reduction, which is done in the operating room under general anesthetic. We use an arthrogram, which you can see in the top picture here, where we inject dye into that hip joint to, again, what we're trying to do is trying to see what the cartilaginous structure that turns into bone, but we can't see on x-ray where it is. And so we can use an arthrogram to make sure that we're getting a good reduction of the hip under general anesthetic. And then we put the child into this body cast, a hip spica cast. And then in my practice, they immediately go down for an MRI, a rapid sequence MRI, where we can look and make sure that our hip spica cast is holding that hip in the socket. Total time that they spend in the hip spica cast is about 3 months. I will change that hip spica cast out in the operating room at the 6-week point, and then transition to a regular abduction brace. Again, as they get older, the problem becomes a little bit more difficult to treat. So once they're above between 6 and 9 months and a closed reduction isn't necessarily successful up to age 4, you then have an increased rate of problems. And so you can try and do a closed reduction where you may need to do cut the adductor tendon if it's too tight in a hip spica. And if that is unsuccessful or you're unable to get it reduced, you then have to move on to an open reduction or a surgical procedure. So again, in the younger patients, you can go through a medial approach, which is called a Ludloff approach, and is shown in the top picture here, where you can cut the psoas and cut the capsule and allow that hip to reduce into the socket and kind of herniate through that anterior capsule. The problem with that is that there is a little bit higher incidence of avascular necrosis, probably related to disruption of the circumflex vessels that provide blood supply. The other thing is that we've got to think about what's causing our blocks to reduction. If you're not able to get a hip reduced through a closed reduction, there's some testable items that show up as the reasons for a block to reduction. That includes the iliopsoas tendon, which is kind of sits in the anterior aspect of the hip and can constrict the capsule. The transverse acetabular ligament, which is at the bottom of the acetabulum, that can be a little bit hypertrophied. You can have a constricted capsule, which prevents your reduction. You can have the fibrofatty tissue called pulvinar. So again, as we talked about at the beginning, the socket and the femoral head kind of develop reciprocally. Well, if that femoral head is not sitting within the acetabulum, it fills in with some fibrous tissue or fatty tissue, which prevents a concentric reduction, and then also an inverted labrum. So one of the other approaches is you can do an anterior lateral approach to the hip, where you can more freely get at all of those potential blocks to reduction by lengthening the iliopsoas, removing the pulvinar, and cutting your capsule. The complications, again, can be avascular necrosis. This is more commonly iatrogenic, meaning that you're putting too much pressure on that head to get it reduced, or you're abducting them too far. That should be less than 5%. Another complication is an inadequate reduction or failure to hold your reduction in the cast and redislocation. And then as that child develops, it's really important that we continue to monitor them to make sure that their proximal femoral anatomy and their acetabular anatomy, quote unquote, catches up and develops normally. Because as they get older, you can treat the residual dysplasia. And again, it's based on age with more advanced techniques and harder surgeries as the child gets closer towards skeletal maturity. We know it's important that we want to eliminate dysplasia because adults that have hip dysplasia or a shallow socket are one of the number one reasons for a joint to wear out early in life. We all think of total hips and hip arthritis being an old person's disease, 65, 75, 85. Well, if you look at the literature, the number one reason to need a hip replacement at a quote unquote young age, so in your 30s, 40s, or 50s, is due typically to either residual Perthes or more commonly unrecognized acetabular dysplasia because of that anatomy change and the increased stress on the cartilage. So in young children, we can treat that with a procedure where we kind of deepen the socket with an acetabuloplasty. As they get older, you need some advanced techniques like a triple innominate osteotomy or a periacetabular osteotomy that we could have a whole separate lecture on. But just the take-home message is that the earlier the dysplasia is caught, the easier it is to treat. And as children become young adults, the surgical management is much more difficult. So the goals here is first off is make the diagnosis, because again, the earlier that diagnosis is made, the less trauma to the family and the baby and the easier it is to treat. And we want to reduce the hip, obtain stability, correct that dysplasia, and avoid any potential complications. Next topic is to discuss Legg-Calve-Perthes disease. So the reason it's got three funny names is that it was described independently, all describing the same thing in 1910 by three separate physicians. And it's kind of gotten shortened that most times we just refer to as Perthes disease. And the radiographic changes were actually described a year earlier by Dr. Waldenstrom. So what is it? It's an idiopathic, meaning we don't know what causes it. Osteonecrosis of the proximal capital femoral epiphysis. So it's a disruption in the blood supply to that proximal femur that causes avascular necrosis. And the resulting process is this concept of resorption and collapse and then remodeling over the course of time. You know, why is it significant? Because again, as we mentioned, this is one of the reasons that patients can have severe debilitating osteoarthritis younger in life. We know it happens more commonly in males. It's typically in the age range of about 4 to 8, the younger patients are when they develop it, typically the more time they have to remodel and their subsequent deformity is less. It's usually unilateral. Frequently on tests, they'll try to test you. And if they show you a case of bilateral, and I actually have a case here of bilateral, it's another disease process called multiple epiphyseal dysplasia, or MED, which affects multiple epiphyses, not just the proximal femoral. So usually it's unilateral disease. There are a whole host of theories as to why this happens. And whenever you see this many things on the potential causes, that means that we as scientists and orthopedic surgeons haven't quite figured out what leads to it. But there's some theories about coagulation abnormalities, the arterial status, perhaps some venous drainage, abnormal growth and development. There's been studies that show some of these relate to trauma. There's an increased association with ADHD. There's hereditary influences. There's environmental influences. So there's a lot of research going into this right now, but the simple fact is that it's idiopathic. We don't necessarily know what causes it. Again, as I mentioned, frequently it's in a male that presents between in early adolescence, age 4 to 10. These children are typically smaller for their age, and they present generally with a painless limp. So mom and dad will bring them in saying, my child's been walking funny for the past few weeks, but he's not really complaining of any pain. When pain is present, it can be very mild. It can also, just like a slipped capital femoral epiphysis, can be referred to the knee because of the neurologic connections between the hip and knee. So again, that referred pain can be the suprapatellar region, the femoral nerve, the medial thigh, or even the buttock. And so if someone comes in with a limp, it's really important to do a good physical exam and radiographic analysis of their hips. The diagnosis is made on plain x-rays. This is how we see that kind of flattening of the epiphysis in a child here that you can see that has bilateral Perthes, where the epiphysis has been flattened. And then we follow it with radiographs as well to watch it go through these stages where you have initial flattening and then fragmentation, reossification, and then eventual remodeling. So when the condition is bilateral, which happens in a rarity of cases, it's usually in different stages between those 4 stages of the disease. How do we classify this? Well, classification schemes are kind of funny, but the easiest way to kind of think about it is how can you talk to other orthopedists and how can you try to relate the amount of disease burden that's going on in the hip. So the most commonly used one today is the lateral pillar classification. And what that represents is how much of that lateral 1/3 of the epiphysis has been flattened. So group A, it's less than 50%. Or relatively no loss of lateral epiphysis. Group B is less than 50%. Group C is greater than 50%. And then as we started getting into it, we kind of developed this tweener stage of the group B and C. Well, why is that important? Is because we know that group A's do really well despite treatment. And we know that group C's tend to do pretty uniformly poorly. And so trying to tease out which of the B's and B/C's do reasonable or going to have a bad outcome. So the prognosis, one of the most important prognostic indicators is maintaining that hip motion, because as the hip goes through this process, the way I try to describe it to families is kind of like the hip turns into Play-Doh, and we want to use the natural acetabulum as a mold because we want that hip to be as round as possible at the end of the remodeling phase. We know that the younger the patient starts developing symptoms, the better, because again, they have more of that potential for remodeling. So older than age 6 to 8 tends to portend a worse outcome because you lose that potential for remodeling. So another favorable prognostic indicator is how much of that lateral column is intact. So less of a deformity tends to lead to less of a deformity down the road. So there is absolutely no consensus in the orthopedic literature on the treatment of Perthes disease. There's controversy throughout on who needs to be treated and what needs to be treated. Most of us can agree that we want to keep good hip range of motion, and that can be done with physical therapy, sometimes even bracing. But there really isn't a good consensus on who needs surgery and who will potentially improve from surgery. But again, the goals are to maintain the range of motion and try to minimize that ultimate deformity and through the process of containment or keeping that remodeling femoral head within the acetabulum. So We know that we want that the femoral head to be as round as possible at maturity, because so the more congruity and the less incongruity you have, it decreases your chance of degeneration joint disease. So the options for that, again, as we mentioned, are PT and bracing, or PT and exercises, bracing, and then whether or not you add in osteotomies on the femoral or pelvis side. So the options on osteotomies are you can do a proximal varus osteotomy or an acetabular osteotomy, again, trying to contain that quote unquote soft femoral head as it goes through the remodeling. The advantages over bracing is that it's definitive, but the disadvantage is that there's been no clear studies that show that long-term that it helps preserve those hips. And so the main indication for operative treatment is if you have this concept of hinge abduction, meaning that as that femoral head is melted and it's no longer round, that as you abduct, you're hinging or almost subluxating that joint. And that needs to be treated to try and get that femoral head back under the acetabulum for future molding. So Legg-Calve-Perthes kind of presents with this short neck, mushroom type deformity of the proximal femur. This leads to secondary problems with the concept of impingement or asphericity at the femoral-acetabular joint. You can have secondary acetabular dysplasia where you get remodeling on the socket side, and all these combination of things then lead to increased cartilage wear and ultimate hip joint failure at a young age. So, what is the future? There's a bunch of folks. Henry's got some great folks at his place that are up at Scottish Rice in Dallas that are doing a bunch of fantastic research and trying to figure out ways to medically treat early the disease process. So is there a potential for treatment with bisphosphonates that inhibit the osteoclast? There's been limited use, but it's currently being studied. Maybe if we can stop that resorption and stop that collapse, it potentially could prevent the ultimate deformity. So there's a lot of good research that's going into this field right now. So in summary, with Perthes, the literature is inconclusive on indications and treatment. We know that regaining and preserving hip motion is critical and necessary before considering any sort of containment type procedure. What you'll frequently be tested on are the poor prognostic factors, which is later onset of disease, so over the age of 6 to 8. If you have lateral hip subluxation or the more involvement of the femoral head, so greater than 50% of that lateral pillar, and then at the end of remodeling, if you have asphericity with an incongruent joint, we know that joint is not going to last long. So the pathogenesis and treatment may be understood with future research.